today we will discuss about the second part of the antiviral drugs. In the previous class, we have discussed about the anti-herpes virus drug, anti-cytomegalovirus drugs, anti-influenza drugs. So from today, we will discuss about the drugs that are effective against the hepatitis B, drugs against the hepatitis C, different other miscellaneous drugs, and lastly, drugs against the coronavirus, COVID-19. Okay. So let's just start. Already we have discussed about this. Now start with the anti-hepatitis drugs. So hepatitis virus, there are hepatitis virus A and hepatitis virus E, which mainly transmitted by fecal-oral route, and they mainly causes the acute viral hepatitis. Now the treatment for the hepatitis A and hepatitis E, acute viral hepatitis, is mainly supportive. That is to support the liver, to support the hemodynamics. So ultimately the patient will be relieved. But there are hepatitis B virus and hepatitis C virus infections, and there are also hepatitis B virus, which usually is infected along with the hepatitis B virus. So hepatitis B, hepatitis C and hepatitis D virus, usually this needs the treatment, particularly when this causes the chronic hepatitis infection. So when there is hepatitis infection with the hepatitis B and C, at the first there will be acute hepatitis infection. Okay. So usually for the acute hepatitis infection, the treatment is just like that of the hepatitis A and hepatitis E infection. Okay, that is only the supportive, to support the liver, to support the hemodynamics, so that the liver function test will come to the normal. Now, many patients ultimately go to the chronic hepatitis stage, and this chronic hepatitis stage is mainly caused by the hepatitis B virus and hepatitis C virus, and that needs treatment with the antiviral drugs. Now, hepatitis B virus is a DNA virus and hepatitis C virus is RNA virus. So, this is the basic difference between these two. Hepatitis B virus usually needs treatment, but this treatment does not eradicate the hepatitis B virus completely. So, we cannot claim that the patient is cured of hepatitis B. Usually, the treatment is given in such a way so that the hepatitis B virus titer will be at the minimum level, undetectable level. Okay. So, in that case, we will stop the treatment for the hepatitis B, but particularly in many of the cases, we have to continue the treatment for the hepatitis B, chronic hepatitis B, for a lifelong or a long period of time. But in case of the hepatitis C virus chronic hepatitis infection, here if we are using the antiviral drugs, that can lead to cure of hepatitis C. So hepatitis B usually cannot be cured, but hepatitis C virus can be cured. And on the other hand, hepatitis C virus is an RNA virus that usually, if not it is treated, that can lead to liver failure, that can lead to liver cirrhosis, and that can lead to hepatocellular carcinoma also. Hepatitis B virus also causes hepatocellular carcinoma, but the propensity of the hepatocellular carcinoma with hepatitis C virus is more than that of the hepatitis B virus. So hepatitis B virus is an HepaDNA virus. It enters within the cell. It is a hepatotropic virus, that is the hepatic cells within the liver. Here the hepatitis B virus enters, and after entering this gets incorporated within the nucleus of the hepatocytes, and after incorporating within the nucleus of the normal host cell hepatocytes, it forms a closed circular stable DNA. This is known as the covalently linked closed circular DNA or cccDNA. Covalently linked closed circular DNA. This covalently linked closed circular DNA is very stable. That's why it basically acts as a template on which the transcription and translation replication of the hepatitis B virus continues and it goes on. That's why hepatitis B virus replication usually goes on lifelong. But if we are using the antiviral drugs, the HBsAg, that is the antigen, ultimately it can goes to the undetectable level. Hepatitis B virus titer, that can also goes to the undetectable level. So that is the goal of the treatment for the hepatitis B virus. On the other hand, hepatitis C virus is an RNA virus that also enters within the cells, and that also acts as a template on which the transcription and translation happens. But since this is an RNA virus, we can effectively use the antiviral drugs so that these viruses can kill the hepatitis C virus. So the cure can happen with the hepatitis C virus. Okay. So already we have discussed this. So you can see there are different areas where the targets are different. Targets, we can use the different antiviral drugs that target different areas of the hepatitis B virus. For example, we can directly inhibit the covalently linked closed circular DNA, cccDNA, which is the stable DNA on which template the replication of the hepatitis B virus happens. So we can block the formation of the cccDNA, we can destroy the cccDNA, and we can silence the cccDNA. So these are the newer modes of the therapy. Usually the small interference RNA therapy and different other therapies are also evolving so that we can directly inhibit or destroy this cccDNA of the hepatitis B virus. So we can use the RNA interference therapy, a small interference RNA, siRNA therapy. We can use immunomodulation like the therapeutic vaccine. We know hepatitis B virus vaccine is there. We can use this. Different antibody toll-like receptor agonists can be used. We can use inhibitors of the HBs release. HBs AG is the antigen, which ultimately is a biomarker that shows that there is hepatitis B virus replicating. So we can inhibit this. We can inhibit the nucleocapsid assembly, the assembly of the hepatitis B virus, and we can inhibit the polymerase. So these inhibitors of the polymerase may be nucleoside inhibitors, that may be non-nucleoside inhibitors. And there are some drugs that inhibits the entry of virus within the hepatocytes. This is known as the entry inhibitors. So these are the different areas. So you can see this pgRNA, pegylated, different types of the interferons are also there that can directly block the replication of this viral DNA as well as the RNA. So these are the areas where the different antiviral drugs act against the hepatitis viruses. So chronic hepatitis virus, usually previously it was only treated with the interferons. So interferons are naturally occurring cytokines in our body that mainly released in large amount when there is viral infection. Now we can synthetically prepare these interferons outside, and we can inject these interferons within our body that have some antiviral, immunomodulatory and anti-inflammatory activity. But the problem of the interferons is there are different types of the adverse effects. That's why it is lesser used nowadays. And also pegylated forms of the interferons are also discovered that gives a more targeted therapy. The adverse effects are less, and the duration of the therapy and the frequency of the therapy is also less. So interferons may be conventional interferon and pegylated interferon, PEG interferons. And there are nucleoside and nucleotide analogs. These are now the first line therapy for the hepatitis B virus infections. For example, there are Entecavir, there are Tenofovir. This Entecavir and Tenofovir, these two are the first line therapies. Apart from this, there are Lamivudine, there are Adefovir difivoxil, there are Telbivudine, and different other newer drugs are also. So these 5 drugs are commonly used. These are nucleoside and nucleotide analogs. They have some direct antiviral actions. So these interferons are in use for approximately 40 years, and this pegylated forms comes in the 2005-2006, and these newer ones comes later. So first coming to the Lamivudine. Lamivudine is the first directly acting antiviral drugs that are effective both against the hepatitis B virus as well as the HIV virus, but this is now used lesser nowadays because newer drugs with lesser side effects are now available. So Lamivudine is a deoxycytidine analog. This is phosphorylated intracellularly and inhibits the HIV reverse transcriptase as well as hepatitis B virus DNA polymerase. So in those patients where there is dual infection with the HIV as well as the hepatitis B virus, we can use the Lamivudine, because this Lamivudine blocks or inhibits the hepatitis B virus DNA polymerase as well as the HIV RNA reverse transcriptase. So basically it incorporates within the DNA and results in the chain termination. So this was the first line drug for chronic hepatitis B. Previously, hepatitis B virus DNA titer is markedly reduced and biochemical histological liver function improvement happens. The rate of resistance is the problem. So many of the drugs, if we are using many of this Lamivudine in patients, if we are using for a long period of time, the patients become Lamivudine resistant, and many of the patients now become Lamivudine resistant. That's why it is lesser used nowadays. Generally, it is well tolerated, have lower toxicity, side effects may be headache, fatigue, nausea, anorexia, etc. Next, coming to the Adefovir dipivoxyl. So Adefovir dipivoxyl is a monophosphate analog of the AMP. So these are the different types of the analogs of the nucleoside analogs, which is active against the hepatitis B virus and some other DNA and RNA viruses, but is mainly used for the against the hepatitis B virus infection. Adefovir dipivoxyl. So again, it enters within the cells. It is phosphorylated. So after phosphorylation, it acts like analog of an nucleoside. So it incorporates an high affinity for the hepatitis B virus DNA polymerase. So it enters within this and directly blocks the DNA polymerase of the hepatitis B virus. So ultimately the enzyme is inhibited. It gets incorporated within the DNA and causes chain termination of the DNA of the hepatitis B virus. So ultimately replication becomes halted. So it is indicated in chronic hepatitis B, including Lamivudine resistant cases and those having concurrent HIV infections. Usually when there is resistant to Lamivudine, we can use this. So side effects may be sore throat, headache, weakness, abdominal pain, etc. Nephrotoxicity, that is toxicity to the kidney, may happen at higher doses. And another problem is the lactic acidosis is high risk, which in those patients who are also taking the anti-HIV drugs, because you can see that many of the HIV infected persons are also suffering from the hepatitis B virus, because the modes of the transmission is more or less similar for the HIV as well as the hepatitis B. So in many of the cases we have to use some drugs that are active both against the HIV as well as the hepatitis B. Next, coming to the Tenofovir. Tenofovir is now one of the main first line drug. So there are different salts of the Tenofovir. You can use, this is a monophosphate nucleotide related to the AMP. AMP means adenosine monophosphate, which is active against the hepatitis B virus as well as the HIV virus. So due to the very low oral absorption, usually ester prodrug, which is a disoproxil, is usually used. Now a newer ester prodrug is also available, which shows more bioavailability. So ultimately all this improves the bioavailability and intracellular passage of the active form. So all these drugs, nucleoside and nucleotide analogs, so basically they act like that of the normal nucleoside or nucleotide that is present in the hepatitis B virus DNA. So this gets incorporated within the hepatitis B virus DNA and blocks the chain termination. So this is the basic mechanism of action of all these drugs. So Tenofovir released from the hydrolysis of the product is diphosphorylated by cellular kinase and then into Tenofovir diphosphate, which preferentially inhibits the hepatitis B virus DNA polymerase as well as the HIV reverse transcriptase. So similar, more or less similar. So affinity for the host DNA polymerase is very low. That's why the toxicity of the Tenofovir for the host cells is less. So it is selectively toxic against those cells which are infected with the hepatitis B virus. So it also gets incorporated in the viral DNA to cause chain termination. Similar thing, Tenofovir. So there are few side effects. There may be some gastrointestinal intolerance, flatulence, loose motions, headache, etc. Good clinical and virological response in chronic hepatitis B. Higher percentage of the patients ultimately responded within 1 year of the use than with Adefovir. So it has been seen that when we are using Adefovir, for example, 1 year, that leads to more virological response. This is known as the sustained virological response, SVR. So this is the biomarker by which we can see whether the virological load in a patient is less or not. So tenofovir resistance usually develops very late. Very less number of the patients have tenofovir resistance, but in those patients who are lamivudine resistant, they are usually tenofovir resistant. Due to its high efficacy, good tolerability and low risk of resistance, tenofovir is now being preferred for hepatitis B virus infection, especially in the lamivudine resistant cases also. Telbivudine, this is a congener of the tenofovir. So basically this is also synthetic thymidine nucleoside analog that blocks the hepatitis B virus DNA polymerase. Similar, more or less similar. Indicated for the treatment of the chronic hepatitis B virus greater than or equal to 16 years with evidence of the viral replication and evidence of the persistent elevation in the serum transaminases. So this is another marker by which we can see that there may be some toxicity to the hepatocytes. Although telbivudine has superior efficacy compared to the lamivudine and adefovir, its use is associated with development of the resistance. That's why it is used in the later stages if it is resistant to the other drugs. So remember the name telbivudine. Next, coming to the Entecavir. Entecavir is also used as a first line drug like that of the Tenofovir. Entecavir is a guanosine nucleoside analog for the treatment of the hepatitis B virus infection. Again, it enters within the cells, phosphorylation happens, it competes with the natural substrate, incorporates within the hepatitis B virus DNA. It is effective against lamivudine resistant strains of hepatitis B virus. Usually this can be given orally, dosing is oral daily. The drug is primarily excreted unchanged in the urine and dosage adjustments are needed in renal dysfunction. Concomitant use of the drugs which have renal toxicity should be monitored. So Entecavir, remember Entecavir and Tenofovir. Tenofovir, Entecavir. These two drugs are basically now used as the first line drugs for the treatment of the hepatitis B virus. So these are the nucleoside or nucleotide analogs. This just like acts as a normal nucleoside and nucleotide is in the hepatitis B virus DNA. So it competes with the normal nucleoside or nucleotides. It enters within the hepatitis B virus DNA. So ultimately this causes chain termination, misreading of the DNA. So ultimately there will be less replication or halting of the replication, transcription and translation of the hepatitis B virus. So after this Tenofovir and Entecavir, if we have to use the other drugs, there may be Telbivudine, there may be Lamivudine, there may be Adefovir dipivoxin. So these drugs are the normal drugs that are used nowadays. Even if it is not responding this, then we have to use or add the different types of the interferons. These interferons are previously used as the first line therapy. Another drug is the Ribavirin. Ribavirin is a drug that can be used both in case of the hepatitis B virus as well as the hepatitis C virus. It is a broad spectrum antiviral activity. This is also active against the influenza A and B. It is active against the respiratory syncytial virus and different types of the DNA and RNA standard virus. So basically this is not a targeted therapy. It is used in a broad spectrum of the antiviral as an antiviral. So when it enters within the cells, virus infected cells, it is changed into mono and triphosphate derivatives and ultimately that inhibits GTP and viral RNA synthesis. Viral resistance to ribavirin is rare. Oral bioavailability is approximately 50%, partly metabolized and eliminated in a multi-exponential manner. It is accumulated in the body on daily dosing and persists months after discontinuation. Long-term half-life is greater than 10 days. So the most common therapeutic use of the oral ribavirin is now in the chronic hepatitis C. So previously it was used in the chronic hepatitis B also, but remember it is used usually as a second or third line agent for chronic hepatitis B, but it can be used for the treatment of the hepatitis C. Apart from this, ribavirin is a broad spectrum antiviral agent that is also active against the influenza viruses. This is active against the respiratory syncytial viruses and different other DNA and RNA viruses. It is administered orally and IV. Ribavirin has been used in severe influenza A and B and also measles, mainly in immunosuppressed patients, as well as for the some herpes virus infections also where the patients are already immunocompromised. Acute hepatitis, but it is not a first line agent in all of these. Nebulized ribavirin is mainly used in respiratory syncytial virus infection. So respiratory syncytial virus infection usually gives rise to the severe dyspnea. So here nebulization is needed. Nebulized ribavirin is usually used in these cases, mainly in case of the infants and children, particularly those with congenital heart disease, prematurely or other high risk conditions. So in those infants who have some heart disease like ventricular septal defect or who are premature, if they are more prone to infected with the respiratory syncytial virus and the baby ultimately suffering from the severe dyspnea, where the inhalational or nebulized ribavirin to be used. So this is one indication where the ribavirin is usually used as a first line therapy. It has also shown efficacy in some rare viral infections. Prominent toxic effects are anemia, bone marrow depression, hemolysis, some CNS, gastrointestinal symptoms, etc. The aerosol by nebulization route can cause irritation of the mucosa and bronchospasm. So similarly, any nebulization can lead to this type of the problems. Now coming to the interferon alpha. So interferons are the previously used. Now it can be used as an add-on therapy with some directly acting nucleoside or nucleotide analogs in case of the treatment in case hepatitis B virus. Previously it was also used in case of the hepatitis C virus, but now it is not used in case of the hepatitis C virus. So interferons are low molecular weight glycoprotein cytokines produced by the host cells in response to viral infections. TNF alpha, interleukin 1 and some other inducers. So it is normally generated in our body when the virus infected our cells. So this can be produced outside of our body synthetically so that it can have some antiviral effects. So interferons. So they have some non-specific antiviral complex effects on immunity, cell proliferation. They bind to specific cell surface receptors and affect viral replication at multiple steps. So they ultimately interferes with the penetration of the virus within the cells. They causes blockade in the synthesis of the viral mRNA. They causes interference in the assembly of the viral particles and their release. But the most widespread effect is direct or indirect suppression of the viral protein synthesis. So viral proteins are necessary for the propagation of the virus from one cell to another. These are usually blocked. So ultimately inhibition of the translation happens when these interferons are used. Interferon receptors are the JAK-STAT receptors. So they mainly act by the JAK-STAT pathways, JAK-STAT tyrosine protein kinase receptors, which on activation phosphorylate the cellular proteins. Normal cellular proteins are phosphorylates. Different second messenger systems are activated, and ultimately these migrate to nucleus, induce transcription of the interferon induced proteins, and these interferon induced proteins have antiviral effects at several steps of the viral replication. Okay. So usually there are three types of the interferons in our body: interferon alpha, beta and gamma. And only interferon alpha, mainly interferon alpha 2A and interferon alpha 2B, these are synthesized, these are crystallized, and these are ultimately developed by recombinant technology for use in different types of the viral infections. So interferon alpha 2A and interferon alpha 2B, these are normally used as a treatment. Both are non-glycosylated low molecular weight proteins, and they are administered usually by the intramuscular or subcutaneous injections. After intramuscular or subcutaneous injections, they are distributed to the tissues, they are distributed to the cells, they are degraded mainly in the liver and the kidney and retains detectable in the plasma for 24 hours. So already we have seen when these interferons are injected intramuscularly or subcutaneously, they enter within the cells, those cells which are particularly infected with the virus, and after entering within these cells, they ultimately form some interferon induced proteins, IIP, and these interferon induced proteins are developed by means of the JAK-STAT pathway. JAK-STAT pathway acts by the tyrosine kinase second messenger system. So this interferon induced protein acts at the several parts of the viral replication, transcription and translation. So they blocks the entries, they blocks the propagation, they blocks the assembly of the virion particles and the release of the virion particles. And also they have some antiviral effects. They directly blocks directly destroys the viral RNA and DNA synthesis. So this is the way by which the interferons act. So cellular effects are longer lasting because the interferon induced proteins persist. So even if interferons we are not injecting, the interferon induced proteins persist in our body for a long period of time, and they ultimately give some antiviral effects for a long period of time, for weeks to months. So interferon is generally administered thrice weekly. Normal interferons are generally administered thrice weekly. So it has been seen that there are different types of the adverse effects. Most commonly some flu-like symptoms may happen, and that's why some pegylated forms of the interferons are developed. So they ultimately leads to more target specific actions. Pegylated interferon alpha 2A and alpha 2B. So it is absorbed more slowly, exerts more sustained effect, permitting weekly administration, that is per week administration. Usually it is given by subcutaneous injections and ultimately improve clinical efficacy. Pegylated form of the interferons. So in chronic hepatitis B, you can see interferon alpha 2A 2.5 to 5 milliunit per meter square or 5 to 10 milliunits given 3 times per week for 4 to 6 months. Ultimately that causes disappearance of the hepatitis B virus DNA from plasma and improvement in liver function test or histology in nearly half of the patients. So usually the biomarker is disappearance of the hepatitis B virus DNA, so that ultimately it goes to the very low titer, but it cannot be eradicated totally. The pegylated form of the interferons is 180 micrograms subcutaneously once weekly for 24 to 48 weeks, produce better and more sustained response. So you can see the duration of the therapy is less. The frequency of the therapy is also less because we have to give some once weekly therapy, pegylated form of the interferons. So this is a finite duration therapy. But for the, already we have discussed about the Tenofovir, Entecavir, etc., which are the nucleoside or nucleotide analogs. They produce more efficacious, more virological response, but usually those needs a long-term administration, usually lifelong. But interferons are usually needed a finite duration of the therapy, usually 24 to 48 weeks. In case of the chronic hepatitis C also, as a last line of the therapy, we can use the interferons. Like interferon alpha 2B 3 megaunit 3 times weekly for 6 to 12 months has produced remission in 50 to 70% patients. Viral RNA becomes undetectable and liver function tests return to normal. So histology improves, the response is sustained. So just remember, interferons can be used both in case of the hepatitis B virus as well as the hepatitis C virus. If we combine these interferons with the ribavirin, that increases the number of the responders and decreases the chances of the relapse. Previously, these are mainly used as a first line therapy, both in case of the hepatitis B virus as well as the hepatitis C virus. But as of now, the different guidelines says that this can be used as a last line of the therapy if the patient is not responding to the nucleoside, nucleotide analogs or direct antiviral drugs. So it can be used as a combination therapy like interferon or pegylated interferon plus ribavirin. So ultimately that is indicated who do not respond to the interferon only. So this can, apart from this can be used some AIDS related Kaposis sarcoma. So in case of the HIV AIDS infection, there are different types of the opportunistic infections. One of these is the Kaposis sarcoma. So it can be used to treat AIDS related Kaposis sarcoma, but it is not used for the treatment of the HIV AIDS itself. The interferon accentuates the hematological toxicity of the Ribavirin. Ribavirin is a drug you will read later, which is an antiretroviral drug for the treatment of the HIV AIDS. But if we are combining this, ultimately they leads to the more toxicity. Condyloma acuminata. This is another virus infection that is caused by the papilloma virus, usually treated with the topical podophylline. So intralesional interferon injection may be used in refractory cases like intralesional. So condyloma acuminata usually happens within the skin. We can use the injections, subcutaneous or intramuscular injections within the lesion itself. So this is known as the intralesional interferon injection. Apart from this, in some selected resistant cases of the herpes simplex, herpes zoster and cytomegalovirus, we can use this as an adjuvant drug. but particularly if it is not responding to any other antiviral drug. Apart from this, it can be used, since these have some immunomodulatory actions, this can be used in some chronic myeloid leukemia, it can be used in follicular lymphoma, cutaneous T-cell lymphoma and multiple myeloma. So these are different types of the cancer or cancer-like situations where, since the interferon is a cytokine, they have immunomodulatory and anti-inflammatory, anti-proliferative actions that can be beneficial. Apart from the viral infection, different types of the hematological malignancies also. So these are the adverse drug reaction of the interferons, and these adverse drug reactions is somewhat less when we are pegylated this, but nonetheless it is present. So flu-like symptoms like fatigue, aches, pains, malaise, fever, dizziness, anorexia, nausea, taste and visual disturbance that may develop few hours after each injection. So when we are using this once weekly or twice or thrice weekly, after each injection the patient may suffering from these problems. There may be some neurotoxicity also. There may be some numbness, neuropathy, altered behavior, mental depression, tremor, sleepiness, rarely convulsion can happen. Myelosuppression like dose-dependent neutropenia, thrombocytopenia can happen. There may be some hypothyroidism or hyperthyroidism. Some problems in the thyroid function can happen. Hypotension, transient arrhythmia, alopecia, liver dysfunction can also happen. So these are the different adverse effects of the interferon. So interferon is very important. So when you are reading about the interferons, you have to know what is the interferons. Interferon is normally physiologically synthesized in response to the viral infections, and what are the synthetic interferons which are used, why it is pegylated, how it is administered subcutaneous, intramuscularly, what are the indications of the interferons, and what are the adverse effects of the interferons. Next, coming to the hepatitis C virus infections. So already I have said that hepatitis B virus usually cannot be cured totally, but hepatitis C virus can be cured totally. But hepatitis C virus is very dangerous. Hepatitis C virus, if it is not treated, in most of the cases it can lead to cirrhosis and hepatocellular carcinoma. So we need treatments. In many of the cases there may be hepatitis B and hepatitis C co-infections also. Many of the patients have hepatitis C virus infection as well as the HIV virus infections also. So again, hepatitis C virus treatment, the first line of the treatment are different types of the direct antiviral drugs. Okay, direct antiviral drugs. So apart these direct antiviral drugs mainly acts at different structural proteins of the hepatitis C virus. Hepatitis C virus is an RNA virus, unlike that of the hepatitis B virus. Hepatitis B virus, remember, is a DNA virus. Hepatitis C virus is an RNA virus. Hepatitis C virus have different types of the structural proteins. Okay, and this type of the different structural proteins are usually targeted by means of the different drugs, so that ultimately this leads to kill of the hepatitis C virus. So several antivirals directly target the various steps in the hepatitis C virus life cycle. So these are known as the DAA or the directly acting antiviral drugs. So previously already we have discussed that hepatitis C virus is also treated by the interferons or the pegylated form of the interferons. Now these are used as a last line of the therapy. So use of the pegylated interferon alpha for the treatment of the hepatitis C virus has largely been replaced by these directly acting antiviral drugs. So available directly acting antiviral drugs, they have fewer side effects, and you can see approximately 90% of the patients will respond. The hepatitis C virus RNA becomes very less, or ultimately it becomes nullified. So basically they mainly target three areas as of now, like NS3 protease, NS5B polymerase and NS5A. So these are the three areas usually the different directly acting antiviral drugs act. So you can see this is the hepatitis C virus RNA genome. So RNA genome, this acts as a template on which the replication of the hepatitis C virus continues. Okay, so there are RNA polymerases also there. So this RNA polymerase can be blocked. So you can see IRS mediated translation and polyprotein processing happens. So different types of the transcription and translation happens of the hepatitis C virus when it enters within the hepatitis, enters in the hepatocytes, that is the normal liver cells. So these are the structural proteins structural proteins present on the outside of this hepatitis C virus. So these are the different types of the structural proteins, and these structural proteins can be targeted. For example, you can see NS5A, NS4B, NS5B, etc. So this can be targeted. So you can see this NS4A is a serine protease or RNA helicase. Basically, this HCV polyprotein processing and viral RNA synthesis is helped by this NS4A, this structural protein. NS5A, this is basically a phosphoprotein that is required for membranous wave formation and viral particle assembly. So in different areas, it basically acts. NS5B is basically a RNA dependent RNA polymerase. So if we can say that is the RNA polymerase inhibitor, is basically a NS5B inhibitor. So RNA polymerase inhibitor means NS5B inhibitor. Similarly, we can inhibit the NS5A, we can inhibit the NS4A. So ultimately, if we are using the directly acting antiviral agents that mainly targets mainly these three areas, we can see NS3A, 4A inhibitors, what it causes? NS3 and 4A mainly is a RNA helicase that usually acts during the pathways of the RNA translation and transcription. So ultimately it blocks the HCV, hepatitis C virus polyprotein processing. This and subsequent decrease of the viral RNA replication can happen when we are using NS3, 4A inhibitors. These drugs usually the suffix is the Previr. Previr suffix means it is a NS3, 4A inhibitor. NS3, 4A inhibitor is an serine protease on RNA helicase inhibitor. Okay. Next is NS5A inhibitor. NS5A, what it causes? NS5A mainly causes the membranous wave formation and viral particle assembly. So when we are blocking this NS5A, so ultimately that interferes with the membranous wave formation, that decreases the viral RNA replication and ultimately release of the virion particles. So usually these drugs are suffixed with the Asvir, ASVIR, Asvir. This suffix is the NS5A inhibitor. The next is the NS5B inhibitor. NS5B is just the RNA polymerase, RNA dependent RNA polymerase. So basically we are blocking the RNA dependent RNA polymerase when we are acting against the NS5B. So it usually causes direct chain termination, inhibition of the NS5B polymerase activity and blocking de novo viral RNA synthesis. Usually these drugs are suffixed with the Buvir, BUVIR. So it is clear. So from this picture it will be very clear, because the treatment of the hepatitis C virus is very complex and newer drugs are coming in every year. But in most of the cases these drugs fall under these three groups. Okay. These three groups, remember, NS4A, NS5A and NS5B. NS4A is also known as the NS3/4A. NS3/4A inhibitor is suffixed with Previr. NS5A inhibitors is suffixed with Asvir and NS5B inhibitors is suffixed with Buvir. Okay. These three types of the directly acting antiviral drugs against the hepatitis C virus. So again it acts. Where it acts? You can see Previr. So Previr already we have seen. So Previr means NS3/4A inhibitor. So NS3/4A inhibitor mainly blocks the hepatitis C virus polyprotein processing, subsequent decrease of the viral RNA replication. So you can see these are the Previrs. So these are the Previrs, it acts here. So example is the Telbivudine, Boceprevir, Cimeprevir, Favipiravir, Patitoprevir, Ritonavir. So newer and newer drugs are now added. So newer, less adverse effects, more targeted therapy. So these are the Previrs. So these are the NS3/4A protease inhibitors. NS3/4A protease inhibitors, different types of the Previrs. Clear? Next you can see NS5B polymerase inhibitors. NS5B polymerase, already we have seen NS5B is the RNA dependent RNA polymerase. That's why it is known as the NS5B polymerase inhibitor. So NS5B polymerase inhibitor example is the Sofosbuvir, Adefovir. Sofosbuvir, very commonly used now as the first line therapy. Sofosbuvir and Dasaprevir. So here it acts. So basically it is a polymerase, RNA dependent RNA polymerase. It acts here. It acts here in the translation areas. Already these two we have seen. Now another one is the NS5A inhibitor. NS5A mainly blocks the membranous wave formation, decrease the viral RNA replication. So here is the NS5A. Example is the Daclatasvir, Ledipasvir and Omitasvir. So Asvir, already we have seen Asvir. So here it acts. So NS5A inhibitors. So mainly it acts. It blocks the membranous wave formation, morphogenesis. So it is clear from these two pictures how it acts. So these three areas, these three structural proteins where mainly directly acting antiviral drugs act. So NS5A inhibitors, example is the Daclatasvir, Ledipasvir, Omitasvir. This is the NS5B RNA dependent RNA polymerase inhibitor, example is Sofosbuvir, Dasaprevir, and this is the NST4A protease inhibitors that ends with the previr like Telaprevir, Boceprevir, Simeprevir, Faldaprevir, Paritaprevir, etc. Apart from this, there are different areas where the different research is also going on so that we can target at different areas of the hepatitis C virus, entry, translation, transcription, etc. So this is the Boceprevir and Telaprevir, which is the NST4A protease inhibitors. Already we have seen the first one. So this is the first oral directly acting antiviral agent. This was first discovered. This type of the drug, this structural protein, these drugs which acts against the NST4A inhibitors. So remember the name Boceprevir, Telaprevir. Boceprevir, Telaprevir. Okay. So basically these are serine protease inhibitors, covalently and reversibly binds to the NST protease active site, inhibits viral replication. They are potent inhibitors of the viral replication, low barrier to resistance. They should be used in combination with the PEG interferon alpha and Ribavirin. Usually these are used in combination with this to improve the response rate and reduce the emergence of the viral resistance. So Boceprevir, Telaprevir. Boceprevir and Telaprevir again, it is usually administered with food to improve the absorption. It is enhanced when it is administered with non-low fat food. Metabolism occurs by the cytochrome 450 enzymes. That's why there may be some interference if we are using some other drugs that inhibits or induces the cytochrome enzymes. So there may be some drug-drug interactions. Remember this. With this Boceprevir and Telaprevir, there are various drug-drug interactions are there. Common adverse effects are usually anemia, dysgeusia, rash and anorectal discomfort, etc. Boceprevir, Telaprevir. Simeprevir is the newer ones, newer drugs. This is the hepatitis C virus protease NS3 inhibitor, blocks the cleavage of the hepatitis C virus polyprotein complex so that functional viral RNA is not formed and viral replication is halted. So they are active against the hepatitis C virus genotype 1 and 4. So there are basically different types of the hepatitis C virus genotypes, usually 1, 2, 3, 4, and it has been seen that some drugs are active against some genotypes, some other drugs are active against some other genotypes. Usually the combination of the Simeprevir and Sofosbuvir, Simeprevir, Sofosbuvir, this combination is commonly used that achieves the sustained virological response approximately 83 to 97% in non-cirrhotic patients after 12 weeks of therapy and in cirrhotic patients after 24 weeks of the therapy. That's why very effective. Sofosbuvir plus Simeprevir combination, very commonly used. It is orally active and should be taken with food to increase the absorption. So all of these drugs should be taken with food. Non-fat-free food, this ultimately increases the absorption of these drugs. Terminal T-half is the 13 hours but is increased up to 41 hours. Usually nausea, headache, dyspnea, etc. can happen. So remember the combination of the Simeprevir, Sofosbuvir ultimately leads to very good virological response. Now coming to the NS5B polymerase inhibitor Sofosbuvir. Already we have seen it is usually incorporated. Sofosbuvir, one of the first line therapy for the hepatitis C virus infection. It is a prodrug which is a 5' monophosphorylated uridine analog. It is an active drug generated in the host mammalian cells. It inhibits the hepatitis C virus RNA polymerase. So basically it is a RNA dependent RNA polymerase inhibitor. It is active against all types of the hepatitis C virus genotypes. It is a cytochrome, not a cytochrome substrate. That's why the drug-drug interactions is very less with the Sofosbuvir. It is a substrate for the efflux transporter P glycoprotein. That's why there are some inducers of the P glycoprotein that can ultimately lead to some drug interactions. Usually it is used in combination with the other directly acting oral antiviral drugs like Boceprevir, already you have seen. So you can see the same thing. This is the structural proteins NS2, NS3, NS5A, NS5B, what the different drugs act. So different drugs ultimately binds with this and ultimately blocks the different types of the protein synthesis mechanism of the hepatitis C virus. The same already we have discussed. Okay. Now the NS5A inhibitor, Daclatasvir. Daclatasvir is an orally active NS5A inhibitor which blocks the hepatitis C virus RNA replication as well as assembly of the progeny virions. It is again metabolized by the cytochrome 3A as well as the P glycoprotein, so that there may be some drug-drug interactions. It is active again all genotypes of the hepatitis C virus. It is indicated in the hepatitis C virus genotypes 1 to 6. Sustained virological response 90% after 12 weeks of therapy in non-cirrhotics. But when the cirrhosis have already happened, usually the therapy leads to less virological response. So we can add the Ribavirin for more improved action. In patients with HIV co-infection with advanced liver disease, it can be used. The T-half is 12 to 15 hours. Again, some headache, fatigue, abdominal discomfort can happen. So Daclatasvir is an NS5A inhibitor. Ledipasvir is a newer one. Usually it is used in combination with the Sofosbuvir. Again, Sofosbuvir, Ledipasvir combination is used as a fixed drug combination, fixed dose drug combinations for the treatment of the hepatitis C virus. Again, it is active against the genotypes 1, 4, 5, 6, weak activity against the genotype 2. In non-cirrhotic patients, again, in all of these cases, in non-cirrhotic patients, the sustained virological response is approximately 90%. But when the patients have already landed up to the cirrhosis, so here the virological response is less. So again, we can add the Ribavirin with all this for the improvement of the virological response. Otherwise, all the mechanisms already we have discussed. Ledipasvir, Valpatasvir is again the newer one, more targeted therapy. Again, it is used as a combination with the Sofosbuvir. So Valpatasvir plus Sofosbuvir. Again, that leads to the more efficacious. You can see the virological response is 95 to 99%. So when we are combined Sofosbuvir plus Valpatasvir, the sustained virological response can go up to the approximately 99%. Otherwise, the mechanism of actions already we have discussed. The adverse drug reactions is already more or less similar. Okay. Grajoprevir, Elbasvir. So these are the again newer ones. Just remember the names. These are the drugs. In all of these cases, if the patients are resistant to the previous ones, that's why the newer and newer drugs are being invented and discovered. But most of the cases, the target is more or less similar. So Grajoprevir or Elbasvir, just remember the name. So these are the again I am recapitulating this. These are the different areas of the hepatitis C virus where mainly these directly acting antiviral drugs act. So it acts at the NS5A, it acts at the NS5B, it acts at the NS3 or 4A. And newer drugs are being invented like Boceprevir. Boceprevir is the one of the newest drugs that also comes under the NS3 4A inhibitor. Boceprevir, Grajoprevir, already we have seen. Boceprevir, Grajoprevir. This is another newer one. Prebentanvir. So it is the NS5A inhibitor. So newer and newer drugs are being invented, being discovered. Just remember some names from each of these groups because this is very important. There are some miscellaneous drugs also. Again, these are one of the newest drugs like Letermovir. This is mainly used in case of the cytomegalovirus infection prophylaxis in adult CMV seropositive recipients of the allogenic hematopoietic stem cell transplant. So what happens when we are transplanting these patients with some stem cell transplant? These patients leads to the different types of the cytomegalovirus infections. So as a prophylaxis, we can use different types of the drugs. One of these drugs is the Letermovir. So Letermovir basically inhibits the cytomegalovirus DNA terminase and ultimately they terminates the chain elongation. The antiviral activity is highly specific to cytomegalovirus and currently it is the most active molecule against the cytomegalovirus with preserved activity against the cytomegalovirus isolates that are resistant to the other antiviral drugs. This is very costly, newest drug. Letermovir, mainly it is used in stem cell transplant patients which are more prone for the cytomegalovirus infection. Maribavir is again another drug that is used in the post-transplant CMV infections that is refractory to treatment with other anti-CMV agents. That is, already the cytomegalovirus infections happens. Here we can use the Maribavir because these are resistant to all types of the drugs. Usually it is oral 400 mg twice daily. It is given 98% protein bound. Main route of metabolism is hepatic. Usually the side effects are dysgeusia, nausea, diarrhea, etc. Basically they act by inhibition of the protein kinase, UL97 protein kinase, and ultimately they impairs the DNA assembly. So these are the different areas of the cytomegalovirus also. So they basically blocks newer and newer drugs, so that in case of the resistant patients we can use this. So Letermovir and Maribavir, these are the one of the newest drugs for the treatment of the resistant cytomegalovirus infections, particularly in post-transplant patients. Okay. Now coming to the lastly, there are anti-coronavirus infections. So already we have seen the COVID-19 infections. So until now, the main treatment for the COVID-19 or the coronavirus infection is the supportive. So different types of the drugs are ultimately, it has been tried, but none of these drugs have shown very efficacious activity against the coronavirus infections. And now when it has somewhat becomes endemic or less epidemic with less mortality rate, the main treatment is the supportive. That is the supportive. That is the symptomatic and supportive treatment. Apart from this, some drugs are usually indicated. These drugs are indicated when there is propensity that the patients may land up to some complications. For example, there are usually 3 drugs that are usually used. One is ritonavir boosted nirmatrelvir. Ritonavir boosted nirmatrelvir. So nirmatrelvir is a drug that is an antiviral drug that is active against the coronavirus infection. But it has been seen that if we are boosted this with this ritonavir, that ultimately leads to more efficacy and more safety. So in OPD settings, it is mainly used as a preferred therapeutic options in mild to moderate COVID-19 infection, which have a high risk of clinical progression to the severe disease, which includes hospitalization and death. Usually it is used greater than 12 years of age and who have weight greater than 40 kg. Usually in the OPD settings, mild to moderate cases. It functions by inhibiting the SARS-CoV-2 3-CL protease. So this is known as the M-Pro. So this is basically a protease of the coronavirus. So ultimately when we are inhibiting this M-Pro or the protease, that prevents the virus from processing the polyprotein precursors it requires for the viral replication. So basically we are blocking the replication of the COVID-19 virus by means of this nirmatrelvir. Now this ritonavir is usually used as a boosting agent, pharmacokinetic booster, to decrease the cytochrome mediated metabolism of the nirmatrelvir. So nirmatrelvir is metabolized very quickly. So if we are using the ritonavir, so ultimately that boosted pharmacokinetically. So co-administration of the nirmatrelvir with ritonavir is needed to increase the plasma concentration of the nirmatrelvir enough to achieve the target therapeutic range. So when we are using this basically acts as a pharmacokinetic booster. So it itself does not have some antiviral effect against the coronavirus infection, but it boosting the action of the nirmatrelvir. Next is remdesivir. Again, there different trials have been done and it has been indicated for the remdesivir, but usually in mild to moderate cases, it is usually not used. So it demonstrated antiviral activity against different types of the filoviruses like Ebola virus, Marburg virus also, different types of the coronavirus, Omicron variety also, paramyxovirus. You can see different types of the para-influenza virus, Nipah virus, Hendra, different types of the respiratory syncytial virus. It has been seen to be beneficial in different types of these viral infections, remdesivir. So this is a phosphoramide product of a monophosphate nucleoside analog. So again it is a nucleoside analog that acts as a viral RNA dependent RNA polymerase inhibitor. So RDRP inhibitor, again RNA dependent RNA polymerase inhibitor, remdesivir, that targets the viral genome replication process. So remdesivir basically blocks the coronavirus replication, and it can also be useful in different other infections also. Lastly, molnupiravir. Molnupiravir is the latest one, which was usually granted approval in 2021 and 2022, which is a product of the ribonucleoside analog N-dihydroxycytidine phosphoramide product of a monophosphate nucleoside analog. So all these are basically nucleoside analogs. Like that, already we have discussed in the hepatitis B virus infection or hepatitis C virus infection. So they are similar to that of the normal nucleoside or nucleotide, enters within the virus infected cells and ultimately blocks the polymerase enzymes. So it acts as a competitive substrate for virally encoded RNA dependent RNA polymerase and introduces errors into the viral genome. So it is a mechanism known as the viral error induction. So due to relatively modest efficacy, it is recommended where other treatment options are unavailable or impractical. So these are the three drugs: ritonavir boosted, nirmatrelvir, remdesivir and molnupiravir. These three are approved for the management of the COVID-19 infections. But remember, usually the first line therapy is the supportive therapy and symptomatic therapy. When the patient is not responding to the symptomatic therapy, is landing up to some serious infections, then these antiviral drugs are usually challenged. Again, the different other drugs, for example, you know about the ivermectin, doxycycline, this has been tried during the COVID-19 infections. There are different types of the anecdotal reports that it may be beneficial, but there are no concrete clinical trials, and the recent guidelines usually says that usually no other drugs have direct any antiviral action against the COVID-19 infections. So this is all about the antiviral drugs. So within the antiviral drugs, you have to read about the different types of the anti-herpes virus drugs, then different types of the anti-cytomegalovirus drugs, anti-influenza drugs, drugs effective against the hepatitis B, drugs effective against the hepatitis C, and drugs effective against the COVID-19 infections. And again, short notes can come as interferon. Very commonly, interferon can come as short note. Directly acting antiviral drugs that are active against the hepatitis C virus, that can come as a short note. Different types of the antiviral drugs individually can come as short notes, like Ribavirin can come as a short note. Already the different other drugs that are used in hepatitis B virus or hepatitis C virus or anti-herpes virus, this can also comes as a short note. So this is all about the antiviral drugs. Just read this because these are quite complex. In both of these two cases, you have to remember the names of all these drugs, at least some 2 or 3 which are most commonly used. Okay, thank you.